like to ask David Chang to come on up. David is, he's, as we all know, an extraordinary surgeon. He has joined the Moran on 2 of our trips to Guatemala and to Haiti. He's a superb team member, great dancer, and a lot of fun. And he does something which that I see every one of these amazing surgeons do. He spends time teaching the our host physicians, and is very patient, but the transfer of surgical skills to our host physicians is really important. So thank you, David, and welcome.
Well, thanks. It's such a pleasure to be here. You know, I always wanted to be a Navy SEAL. I just thought nothing would be more glamorous. Unfortunately, I didn't meet the fitness requirement. But the next best thing is to go with the Moran team on one of these trips. It's exactly, it kind of has the same feel to it. You know, this is a subject I'm very passionate about. And I think one of the problems is, you know, there's a saying, if you're a hammer, everything looks like a nail. Well, if you're a phaco surgeon, everything looks like it should be phacoed, and that's what we should teach. And that's, in fact, what often the local doctors are interested in. First of all, you know, this is really, to me, the biggest challenge that we have in cataract surgery. It's not an accommodating IOL, but it does bring up this question of how we're going to meet that challenge. So I just want to share a couple studies. This is a really nice way to look at here the prevalence of blindness and here the rate of ophthalmologists. And you see where the discordance is greatest. It's in Southeast Asia and it's in Africa. So we know that the phaco is a big part of the problem, the purchase cost, the supplies, shortage of surgeons able to do this, particularly the really advanced cases that here you would never let a junior resident tackle, and then the poor access with the follow-up. So how do you get something that's affordable, that can actually maximize productivity and be high volume, but most importantly, reduce complications in countries or settings where you don't even have a vitreoretinal surgeon, and that's really the challenge. So you all know about costs and how much greater phaco will increase that versus manual small incision, as well as with the consumables. But the question always comes up, so we're doing this manual extra cap, how much are we giving up in terms of quality? Because we know the cost is the driving factor, but we all know why we prefer phaco. It's for all of these reasons that you see here. And how much quality are we sacrificing? So we did a randomized controlled study, or a randomized study, back in 2007 is when it was published. The study was in 2005. And the question was, not so much could you do phaco as well in a schoolroom, but if you take the same patient population, which is very different, which would be better, phaco or manual extra cap? And so what was unique was we did this in Kathmandu, but we did it in a charitable population where they had an address, so they could get these people followed up and, in fact, provided transportation for exams for a year. They were screened, and then those that qualified were brought to a monastery, so it wasn't in the main Tilganga hospital, where they were lined up for the surgery with a full assortment of exams. So we had really good data, including biometry, keratometry preoperatively. And then after they got washed up, they wash their face, they have the block, they get randomized. And so it happened to be a ping pong ball. And so depending on your luck of the draw that day, you either had phaco by me or manual small incision by one of the true masters, Senduk Ruit. So it's really a randomization of this population. Dr. Ruit's OR, they had 2 OR tables. This is just a classroom in the monastery. There he is operating here. And then this was me. And they went to great lengths to bring my machine at the time. AMO donated a Sovereign machine. This is the full Zeiss microscope. I used AMO lenses, viscoelastics, so to give me every advantage that I might enjoy at home. The difference is we're operating on patients in Nepal. And this was not the same as California. Surprise, surprise. I know, 1 out of 5, 1 out of 4 hand motion cataracts. This is the average preoperative acuity, and that was the challenge. So this is just sort of a day's worth of patients. This was kind of like the 4 seasons for them because it was in the prayer hall of the monastery, and we did these surgeries. Now, what was different about it besides the randomization was the follow-up. There is no other study that I'm aware of that has this kind of follow-up prospectively for a year out, looking at uncorrected as well as corrected acuity. And of course, in a population that doesn't have lens crafters, uncorrected acuity is important. We looked at PCO scores, and of course, you're going to ask, who won? So, as you might expect, we actually included turnover time, and this is doing things that would not pass muster with the surveyors from Medicare. But even then, working as fast as I could with no essential turnover time, I certainly could not hold a candle to Dr. Ruitt. Complications were actually good in both groups. And to this day, I don't know how I got away with just 1 case of vitreous loss, because these were cases I just couldn't see. They all had bad tear films, using trypan dye a lot, and a lot of really brown lenses. And I just knew we were doing a prospective study. We tried to publish it, and I was just dreading, Chang, 25% drop nuclei. So instead, but this one case here, I actually did a PAL technique. I got it out. I converted. I mean, it would have been a great teaching case, but it took 45 minutes. And at that point, they told me if I didn't get my, act in order, we wouldn't finish the study because we only had a day and a half to do all these patients. So the astigmatism. Well, this was pretty amazing because they're doing sutureless, temporal, small incision surgery, and look at the keratometry as well as the refractive astigmatism. It was the same. Uncorrected acuity is really important, right? Because that's going to determine whether people tell their friends want to come back, whether they're going to get their other eye done, or, of course, many of them don't have glasses. And there was really no difference. There actually was a difference. I had a lot more corneal edema on day 1, and so my patients don't see so well when you take the bandages off. Whereas the manual small incision, those are the ones that are jumping up and down and dancing because they have clear corneas. This is uncorrected at 6 months. It's about the same. This is, again, a function of biometry and astigmatism control, uncorrected at a year. Now, the one thing is, and this is the thing we always have to tell people, especially if they're from the American press, is no, we cannot do cataract surgery in the United States for, $50 an eye. But we're also using 20/60. And your patients and my patients, if you're American, they're wanting 20/20 without glasses. And so it wasn't the same, but this is the World Health Organization definition of what would be functional vision in basically a population largely illiterate, not driving a car, let alone at night. So best corrected, all right? That's the same at 6 weeks and at 6 months, and you can see here that this is 20/20 to 20/60, best corrected at a year. Now here, finally, I'm ahead. It took a year. And why was that, do you think? Well, it's because of PCO. And Dr. Ruitt was not making a CCC, I was, and this is just looking at the PCO scores, objective scores, and by that time, PCO was happening. So lesson here is you can do a great surgery and PCO can still be a problem. So this was published in AJO, and the results were a 2-to-1 advantage to MSICS in terms of time, 4-to-1 in terms of cost per case, vision basically the same, uncorrected, corrected at 3 weeks, out to a year, and safety the same. So here's the advantages now as they lined up. Astigmatism the same, rehab is actually better early on with M6, and although I said the same on safety, I got to tell you, if we did 1,000 cases, there's no way, because we are dealing with the kind of cases that you see once a month, once a year maybe, and you kind of block out an hour and put them on the end of the day because you just know you're in for a lot of trouble. I'm really blessed to be able to collaborate with my good friend, Dr. Aravind. She's the head of cataract surgery at Madurai Hospital in Aravind. And I think that you all know about what they're able to do there. I mean, if you're a cataract surgeon, going to Aravind Eye Hospital is like going to Disneyland. And so we have a lot of fun dreaming up studies to do on their incredible population. And one of them was to look at the complication rates in a very large series of Phaco versus manual extracap, and this was published in 2012. Sorry, here. So the purpose is to really look at intra-op, endophthalmitis, complications. Which of these is safer? Comparative safety, also looking at experienced versus inexperienced surgeons like trainees. What's amazing about them is they have a wonderful EMR system. I don't know why with Microsoft and Apple we can't get a system that works in the United States, but their system really works. And they have data then on everybody, and they have scribes, it's basically their staff, that they enter this. So this is looking at one hospital of their 5 during a 12-month period. It just happens to be 80,000 cases. And look at the breakdown in terms of surgeries here. You see most of them are in this category because, of course, about 70% of their cases are done free of charge on their charitable population. So Phaco is mostly the private paying patients that get that done. So there's the 80,000. And what you see is that the complication rate is really about the same. Extra caps, that's a selection bias. They'll do an extra cap if there's like phacodenesis, something really, really bad. So that's why that's a little bit higher, but amazingly not that much more so. But what gets interesting is if you look at the experience, staff as their surgeons, then they have fellows, residents, visiting trainees who might be from Africa or Cambodia. So this is declining experience there. And as you'd expect, the complication rate goes up. That's true whether you look at MSICS or whether you look at Phaco. The less experienced you are, the greater the complications. But if you look at these groups, so an experienced surgeon at Aravind, you get so much volume, you're going to be good at whatever you do, and you see that it's about the same in their hands. It makes no difference. So that's pretty good. It means the complication rate is no higher with one or the other. But then as you go to a fellow or a resident, or a visiting trainee is a person that's actually going to go back and maybe be the only cataract surgeon in their city in sub-Saharan Africa or their village. Look at how much higher the rate of complications was with Phaco. We can sort of show it here. Phaco is in purple, dark red or crimson is M6, and so staff is about the same, but when you get to residents and visiting trainees, it's a lot higher. So it may look good there, but although there was no difference in the experienced surgeon groups, with less experienced surgeons, much higher with Phaco. It's an unforgiving platform. They don't have the benefit of an American residency. And so our conclusion for this was that for the type of less experienced surgeon, M6 is the way to start, M6 is the way to go. The third study that I'll highlight is sort of an offshoot of your first reaction when you go to the developing world. And it's like they're breaking like 4 out of 5 rules we've had since medical school about aseptic technique and masks and everything else. And you're kind of a little horrified at first. So my first trip at Aravind was 2003. And so naturally, I told them, this is before the ESCRS study, but I said, once I used intracameral vancomycin, my infection rate went way down. And this would be a way that would allow you to, I get it. The more you can lower costs, the more blind people you can cure. And this might be a way to sort of counteract whatever we're giving up in terms of infection rate. And that was 2003. And we had these discussions for a decade. And finally, I was able to convince them because in their manual small incision rate, some quarters they would have as many as 8 to 11 infections per 10,000. And it was definitely higher than their Phaco private patients. It kind of makes sense, right? It's a poor population, poor hygiene, larger incision, poor follow-up. Are they going to take the topical drops? So we did this study. And they said, let's start with the higher risk group, the charity patients with large incisions. And they said, as of this date, we'll do it. Everything there is done according to protocol. And so when we did that, we went back and took about 38,000 eyes. And then we said, let's collect data on the consecutive 38,000 after we institute, and they chose intracameral moxifloxacin. So this is the largest study, and it was done in 14 months because of their volume, which strengthens a retrospective study where other things can't be changing, a 5-fold reduction. So this is just showing you 30 infections in the 6 months. This represented 6 months prior to routine installation of intracameral moxi in the charity patients at this one hospital. It took us 8 months to go out, but you see the infection rate 6 versus 30 in a similar number. They actually have their own pharmaceutical company or division, and they manufactured moxifloxacin for the eye. You know, the pH, osmolality, using 0.5 milligrams per 0.1 ml. So this is, an autoclavable vial. It's 1 mLs. It costs slightly under $1 US for it. And if you, like everything else at Aravind, don't waste anything and you use this for 5 or 6 patients, you're bringing the cost down to below 20 cents in administration. And this is just showing, like I said, some quarters the rate's a little higher, right? This is 19 per 10,000, but the rate was always, and this is when we started it, and I can give you more follow-up now out a year. It's continued out there. Now what we also had is they collected data on the private patients that didn't get intracameral moxi because the thought was we're doing so well there, an infection rate of 6 per 10,000, that's pretty good. But what we didn't expect was the infection rate in the intracameral moxi group dropped from 8 per 10,000 to 1.6, better than the Phaco private group. So you add this up, and that's 116,000 cases. So what I can tell you here, and Dr. Harapriya presented this this morning, is that they then switched over to intracameral moxi in everybody, all the Phaco at all 5 hospitals. And what she presented, and we'll write up, is 500,000 patients, 250 before and after. And now what we know is this holds true for Phaco as well. It holds true for Phaco as well. Of course, they look at cost, right? Because again, the more you spend, the fewer blind people you can treat. And so the neat thing about that was that there was a cost. Even at 20 cents an eye, it adds up after a while. But it was exactly offset by the savings in not having to treat the 24 endophthalmitis patients. So it just balanced out pretty darn well. So the reason I think this study is important is, this is where these surgeries are going done. And you kind of wonder, okay, it's a developing world, but this is not like America. It's not like my operating room. We have to save this money. What are we doing there? And now to think that for 20 cents an eye, you can save, on the one hand, all of this other redundancy that Medicare would require me to do in my operating room, and you can get an infection rate of less than 2 per 10,000, which would rival any institution in the U.S., is pretty empowering. So the conclusions of these 3 studies, which I think are kind of neat, are manual small incision for the type of vision that population needs, does just as well as Phaco at a fraction of the cost and the time. For people that are having to go and practice on their own, where there's no one to fish out a drop nucleus, manual small incision is great because you don't ruin the cornea and you don't drop a nucleus. And then finally, this was the first study. There have been many retrospective studies on cefuroxime. It's really the first study on moxi using manual small incision. And I think it kind of makes the case that everyone having manual small incision should probably have a few drops of intracameral moxifloxacin. And now, particularly with HORV and the concerns about vancomycin, this new study that we'll publish is the largest now for moxifloxacin efficacy, and argues that may be a viable alternative given the concerns about vanco. So I think, Sue, you wanted to have a couple points of discussion, but thank you very much.